Good evening, everybody. My name is Roxanne Chabot from RBC Consultants. This evening, we're going to be reviewing with you an algorithm developed by experts for patients with oncology treatment-related skin toxicities. As speaker, we have Dr. Charles Lind. Dr. Lind is Chief Medical Director at the Lind Institute for Dermatology and Linderm Research, as well as Associate Professor at the University of Toronto Department of Medicine. We also have Dr. Maxwell Sauter, who is oncodermatologist at the Princess Margaret Cancer Centre and Director of Pigmented Lesion Clinic at the Toronto Dermatology Centre. We would like to thank our sponsors, La Roche-Posay, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your question in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up in your web browser following the webinar and will be emailed to you 1 to 2 days later. We'd greatly appreciate it if you could fill it out and send it back to us. And within 1 to 2 days of the webinar, the recording of this program and our certificate of attendance will be emailed to you. Again, if you want to submit your questions using the question chat pane on the right-hand side of your screen, I wrote a little note there so you could see where you need to type in your question. So without further ado, I am going to pass the floor virtually to Dr. Charles Lind.
Well, on behalf of myself and my co-host, Dr. Max Sauter, welcome to this informative webinar tonight. You're going to learn a bit about skin cancer and skin cancer treatment and overall treatments of other malignancies. And it's actually kind of a paradox to me that in Canada, we have about 1 in 2 Canadians at some point are going to develop a cancer in their lifetime. Now, there's been little done and little written about this. And really, I think this is what we came to, and we've developed an algorithm surrounding this and some further papers, and now we're sharing some of this with you. Just have to get rid of something on the computer here. Okay, so I'm going to start off with a polling question. And the first polling question, are you comfortable in recognizing and managing patient skin toxicities during cancer treatments? And these are all cancer treatments, whether it be from chemotherapy, radiotherapy, the new immunotherapies that are done for cancers. And would you please select one? Yes or no? This is just a general idea before we start the meeting. Yeah, so I think that's why a lot of people have come onto this thing tonight. Really, about 2/3 of you say, I really don't know, and I don't know how to manage a lot of the new skin toxicities that we're seeing with a lot of these new agents that are coming up. So the objectives for tonight are outline, describe the different modalities for treatment of cancer in patients, the most common skin reactions from different types of cancer therapies, and be able to discuss skin care measures for cancer treatment-related skin toxicity, prevention and management to improve patient outcomes. Oops, okay, got to go back one here, sorry. So there was a number of Canadians across the country. We came across with basically dermatologists, radiotherapists, and oncologists to create a number of different sort of initiatives. The very first initiative was a grouping that we did for the skin therapy letter on raising the awareness of skin toxicity and importance of skin care. And it really was more of a holistic type of approach. With our March edition of this, we looked at Canadian general algorithms to manage these skin toxicities. And a subsequent one that's going to come out in November 2021 was looking at skin toxicity surrounding radiotherapy. And this is, all of these I think have been very beneficial. You can get them through open access through the skin therapy letter. And it was developed to improve patient outcomes through the prevention and management of cancer treatment related skin toxicities. So the first consensus article had a lot of just kind of motherhood things in there, talking that these toxicities can occur at any time during cancer treatment, including well after the time of discontinuation of the treatment, whether it be radiation or immunotherapy. We know that these toxicities have a major impact on a person's quality of life. We said that patient education, the therapeutic relationship, and frequent open communication between the oncology team and the patient and the family physician and the dermatologist is very important. We looked at the patient holistically, acknowledging the factors involved in their access to resources and the willingness to adhere to recommended practices. This toxicity team might improve patient outcomes, such as reducing the risk of disruption of cancer therapy and improving adherence to that therapy. And we proactively initiated a simple regimen involving hygiene, moisturization, and sun protection. It's the first step in the prevention of these toxicities. The second article, as I mentioned, really developed an algorithm around this to develop and look after the skin toxicity, manage and improve patient outcomes. And my good friend, Dr. Max Sauter, will be talking about that in his half of the talk. This is a cancer overview in Canada. I'm going to ask you a polling question here. You bring up the polling question. So of these 5 here, which one is false? A, B, C, D, or E? Cancer is #1 cause of death in Canada. Prevalence of melanoma is 1 in 5 Canadians. 5-year cancer survival is about 63%. 1 in 2 Canadians will develop cancer in their lifetime, and 1 in 4 Canadians will die from cancer at some point. Can you vote? Have we got all the votes there, Roxanne?
Here they come.
Okay, so this is the things. So which one is wrong? Okay, so several of you picked several different ones. And here's the answer. Back one. So in fact, I found that quite interesting. Cancer is in fact the #1 cause of death in Canada. I guess excluding maybe coronavirus right now. No, it's still #1. 1 in 2 Canadians will actually develop cancer in their lifetime. The 5-year cancer survival is about 63%. 1 in 4 Canadians will die from cancer, and 83,000 Canadians will die of cancer in 2020. And it's estimated that about 225,000 Canadians will be diagnosed with cancer in 2020. So the one that was false was melanoma, not 1 in 5, but melanoma is certainly creeping down there. And in terms of the incidence of melanoma in Canada, it's about 1 in 60, 65, or 65. So the 4 most common diagnosed cancers in Canada: lung, breast, prostate, and colorectal. Of course, we all know that skin cancer is by far the #1 cancer, but it doesn't even fall into the statistics. And tonight we're really talking about all cancers in general, but it's estimated that of these 4 cancers will account for about half of all cancer diagnoses of those that are kept track of. It's actually a pity that squamous cell carcinoma, basal cell carcinomas are not kept track of, because they are by far the #1 cancers in Canada. So the cancer trends in Canada, we know that the incidence of cancer is increasing in the population. The mortality rate is dropping quite considerably because of better care in Canada and because of a number of the newer drugs and our ability to treat cancers in Canada. And the 5-year survival rate is increasing. What does this mean? More Canadians are living or surviving with cancer. More Canadians with cutaneous changes or sequelae of anti-cancer therapies are going to be seen. They're going to be seen by family doctors. They're going to be seen by us as dermatologists, and they're certainly going to be seen at the cancer centers. And it's important, particularly for us as physicians, to recognize this and to recognize some of the patterns and which ones are more urgent to treat and be sent to a more specialized person to treat them. And these are frequently unanticipated. About 70% of patients reported that their cutaneous adverse events were worse than their initial beliefs before the start of treatment. And it's widely held in the population that, woo, you're going to get on this treatment, you're going to have all kinds of side effects. And 70% of people said, hey, they were actually worse than what I thought they were going to be. And a prospective study showed the frequency and impact of the quality of life of skin cancer receiving chemotherapy showed that about a third of them that the skin adverse events were the most important during treatment, and they were the most common significant contributor to overall quality of life. And of those who developed the skin toxicity, about 70% felt it's significantly limited in their daily activities. Again, just to suggest that there's been a number of studies. This is one that was a small cross-sectional online survey, only about 55 cancer patients receiving care, and that's basically looked at their patient satisfaction, quality of life, and that if you actually had some good dermatological care, it resulted in better overall satisfied patient outcomes. In this study, however, the influence of the care on the cancer treatment adherence was not clarified. So we're going to talk about some of the most common skin toxicities associated with these anti-cancer therapies. Anti-cancer therapies, the non-targeted chemotherapy, the radiotherapy, the more targeted ones, and I'm going to talk about a number of these, and Dr. Sauter is going to talk about immunotherapy and the algorithm at the end. But I think you all know and you remember surgery is used for quite a number of them. There's certainly morbidity and mortality is surrounding this, but certainly radiation. And up until recently, the radiation oncologist basically said, don't touch it, don't do anything with it, don't use a cream, don't do anything to it, just leave it alone, let it slough off everything. And then we know that certainly systemic therapies such as chemotherapy and immune checkpoint inhibitors have a number of different toxicities associated with them. We're going to review some of these as we go along here. So, chemotherapy, simplistically, it aims to disrupt these specific phases of the cell cycle. And the adverse events occur primarily while the patient is on the treatment, and the sequelae of the anti-metabolites can occur on many organs, including uninvolved organs. This is obviously one that I certainly see a fair amount being associated with the cancer agency. Antigen effluvium, this is particularly with cisplatinum and the Taxols. And this is something that is very devastating to a number of women in particular. I mean, they're already feeling unwell, and then they lose all their hair. They have difficulty finding a wig, and we actually have within our front desk here a number of wig manufacturers that we suggest to them. We do suggest that, in fact, this may be a little bit of money. A good wig in general costs often about $2,000 or $3,000. However, if you explore with them, there are agencies that can help them with the getting these wigs. And often people have insurance when they go looking at it. They're working for one of the big banks, and certainly if they're working for the government, there's often funds to provide for these wigs. Again, sometimes the inflammation of the pre-existing actinic keratoses, the carboplatin, basically like a 5-FU type of thing, brings out the actinic keratoses. In fact, that was where Effudex came from. It was found that the 5-fluorouracil actually inflamed all the actinic damage, but in somebody that's had a lot of actinic damage, will get a fair amount. But recognizing this is a side effect, and I usually tell them this is somewhat beneficial often because they're going to get rid of their actinic keratoses, and I won't have to spray them off. This is one that I think all of us as physicians should recognize, so-called PTEO, the periocular thenar erythema and onycholysis. This is particularly with the Taxols, and you can see the damage to the nails, lifting up the nails, the subungual hematomas there, and you can see the damage to the back of the hands, producing this sort of almost psoriasiform eruption. Certainly the busulfan and ones similar to that can cause this intertriginous reaction. Once you've seen some of these pictures and looked at them, you go, oh, yeah, that's pretty typical of what I'm seeing in some of these patients. And again, intertriginous reactions. This is from Dr. Rubinson. Again, underneath the breasts, in the axillae, and you can see this pattern along the belt line. It's a fairly common one, and when you see it, you recognize it, and you'll recognize it subsequently. And here's just a long list. And again, up to 40% of patients undergoing chemotherapy presented with cutaneous adverse reactions. Most often the antigen effluvium, but dryness of the skin, itching of the skin. I've seen melanechia with it, hand-foot syndrome, which we're going to talk about in a few minutes, flagellate dermatoses, even prurigo nodularis, ichthyosis, and a number of other things. I've seen a sweet syndrome also with this. Radiotherapy similarly causes a number of reactions. And again, 30 to 40% of cancer patients receive radiotherapy during their disease trajectory. Again, often for lung, often for breast, often for localized ones with lymphoma. And it's used widely, and again, quite widely at many different centers. And I think most of us can recognize the kind of radiation burn you get. You can see on the neck there, it's sort of a more mild case, and then a much more severe case where there's actually erosions and ulcerations. And again, occurs, this is how the radiotherapist actually, I think, knows he's done a good job, is if he gets that radiation dermatitis. Again, 90% of head and neck patients get this. About, again, 90%, 87% of breast cancer patients get it. And the reactions are limited to the irradiated area. And it's dependent on the target, dose, and the treatment schedule, whether they're going to do it aggressively. And this is often used with other anti-cancer therapies, so you can get other toxicities associated at the same time. And again, 1 to 4 weeks, you get a mild redness, get a mild itching, desquamation, but it can be severe. You can get ulceration, severe pain, bleeding, and certainly we all recognize that chronic changes can occur in that area. You can get telangiectasia, atrophy, fragility of the skin, and you can actually get necrosis under the underlying cartilage and bone, and subsequently fibrosis in the area. And these are just some pictures, again, showing the erythema, the burning, then more severe ones, again, with actual ulceration and more deep ulceration that might occur. Now, again, chronic areas, sort of fibrosis, scarring, tightness, particularly that one in the head and neck, number B. Again, you get the sort of changes of telangiectasia and subsequent damage to the skin. And you know that subsequently you might get a secondary malignancy in this area that may be 10, 15 years down the line. And again, targeted therapies also have their ones that can occur. And we know there are monoclonal antibodies, they're small molecules, and there are targeted therapies in the microenvironment. And these are just some of the examples of many of the different drugs that are used widely by our oncologists. So one of the more common ones that I see anyway is the hand-foot skin reaction. Onset again about 2 to 4 days to a couple of weeks. Scaling, swelling, redness, then dryness and peeling. You get hyperkeratotic areas with or without blisters. You get thickened painful lesions. And again, more pronounced in areas of increased pressure and friction, as you can see in these pictures here. Just to point out that not all hand and foot reactions are the same. You can get the one that we just previously talked about, pateo. Dorsal hand-foot syndrome is another name for this. The hand-foot syndrome, again, with the palmoplantar erythrodysesthesia and acral erythema that's been called before. And again, the hand-foot skin reaction that has also been talked about. And this is just a little chart that talks about these different ones and what's different. And this, for the most part, different drugs cause different things. And you can see basically the changes and where it is. The pateo, again, tends to be on the dorsal and the Achilles tendon and the malar prominences, whereas the hand-foot syndrome tends to be diffuse on the ventral surface of the soles. And again, the hand-foot skin reaction, again, heels and forefoot. And you can see there are different ways of potentially doing it. Again, steroids can be of some use, and again, non-steroidal anti-inflammatories, and again, even sometimes acitretin can be useful, particularly in the hand-foot syndrome skin reaction. One of the other ones that we're, I think, all aware of, again, is the papulopustular eruption that occurs with the EGFR drugs in particular, but also MEK and HER2 ones, and you can see the list of different ones of drugs. Again, you have to keep up to date on all these. There's constantly changing. It's good to be friends with an oncologist who you can text them and say, you know, what's this one? The patient just gave me the trade name or something. What should I be looking up? To be able to go and look it up and be able to find what the reactions are likely to be, and to then classify that person, and then find out what you should be doing in terms of treatment. And again, EGFR changes, and I think we all recognize that the reactions that you do occur, particularly the active form eruption, actually shows that the drug is working. And so you're able to tell the patient, well, you don't look great. However, this does say that your drug is probably working for your cancer. And again, the acne-like rash usually occurs in the first week and a half sort of deal. You then go on to have post-inflammatory changes, the dry skin, subsequent fissures, and you might even get perinichial changes often, but these can be late. They can be down 8 weeks after you've actually been on the drug. So I'm going to turn the podium over to my good friend, Dr. Max Sauter. Max is going to talk about immunotherapy in relationship to skin toxicities, and then talk about the sort of holistic approach in our algorithm that the group came up with. Max is a oncodermatologist at Princess Margaret and well-versed in this. He spent a great deal of time at Harvard and trained a lot in this area. And any reaction, I think Max can look after, much unlike Dr. Lind, who can't look after many of these. Max, go ahead.
Oh, I don't know about that, but thank you very much for the kind words. So I'm going to take over from here and talk briefly about immunotherapy. Immunotherapy really presented a paradigm shift in how we're managing malignancies. So for the first time, we've actually unleashed the body's immune system to attack tumors. And there are a variety of mechanisms that are currently Health Canada approved, and a variety of mechanisms that are currently under investigation that I'm seeing in clinical trials. But the gist of it is that we have three main categories: CTLA-4 inhibitors, PD-1 inhibitors, and PD-L1 inhibitors, which is just the ligand of PD-1. And essentially what they do is they take the brakes off the body's immune system. And unfortunately, when we do take the brakes off the body's immune system, we tend to overshoot it. And so the most commonly observed reaction across all of them is actually rash. So that happens generally in about 30 to 40% of all immunotherapies, CTLA-4 being the least specific, and the most specific one would be anti-PD-L1. But the immunotherapies can overshoot the response and create auto-inflammatory syndrome. So that could be auto-inflammatory dermatitis or inflammatory skin conditions. You can get thyroiditis, you can get pneumonitis, you can get colitis. And the management of these varies based on the presentation. In terms of the cutaneous immune-related adverse events, the most common ones that I see are pruritus, eczema, psoriasis or psoriasiform immune-related adverse events, lichenoid or lichen planus-like immune-related adverse events, vitiligo, and bullous pemphigoid. But literally You could go to a dermatology textbook, and anything that's in the textbook has basically been reported as an adverse event for immunotherapies. Here is probably the most common presentation for cutaneous immune-related adverse event, which is pruritus without primary dermatologic findings. So really all we're seeing here are secondary effects of scratching. But you need to rule out underlying inflammatory dermatoses or even a pre-bullous pemphigoid in these patients. Lichenoid immune-related adverse events. So this looks just like lichen planus, polygonal, purple, planar papules that have slight scale overlying them. They can have cutaneous involvement. They can have mucosal involvement. They're often found on the legs in particular, and often can be quite hypertrophic. Sometimes it's difficult to tell whether this is in fact a secondary malignancy, like a squamous cell carcinoma versus hypertrophic lichen planus. And sometimes for some of the more guttate papules, it's difficult to differentiate between this and the psoriasiform immune-related adverse events. So if you look at the picture labeled B, that could be very challenging clinically to differentiate between lichen planus. But you could certainly see psoriasiform reactions with silver scaly plaques on the extensor surfaces, as well as nail involvement in many of these patients. And some of these patients may have had a history of psoriasis that then flared with immunotherapy, but many of these patients don't have any pre-existing history. Bullous pemphigoid is always one that's in the back of my mind. I do tend to see this more so with patients on immunotherapy for other malignancies beyond melanoma. So things like non-melanoma skin cancer, non-small cell lung cancer. And whenever I see a patient presenting with pruritus out of control or out of proportion to what I'm seeing on their skin, I always have at the back of my mind bullous pemphigoid. It often goes through an urticoid phase where it looks like urticaria, but then it often blisters. Sometimes when we get to the patients, like in my patient at the bottom, you really just see the sequela of ruptured bulli. Vitiligo is a very common one that is seen with CTLA-4 inhibitors in particular, but it can be associated with any immune therapy. Then finally, one of the most dangerous and clinically impressive ones would be erosive mucocutaneous immune-related adverse event. So on the most severe spectrum of this would be SJS or TEN-like reaction. However, sometimes an even very inflammatory lichen planus-like eruption can result in bulli or skin detachment. So how do we manage these skin toxicities really is the question. And there have been a variety of societies and guidelines that have proposed different algorithms for the management of skin toxicities, and particularly immune-related skin toxicities, but really all skin toxicities. However, most of these organizations do tend to be oncology related organizations, and may or may not actually have dermatologists associated with the groups, and may or may not have a dermatology perspective incorporated into that. So, with regards to skin toxicities of anti-cancer treatments, dermatology or oncodermatology, we know can make a dramatic difference in patient lives and outcomes. We know that we can improve patient quality of life, patient satisfaction, and the goal is really to decrease treatment interruption or discontinuation through increased adherence and ultimately improved outcomes. However, we don't exactly have all the evidence showing the benefit of oncodermatology yet. So there's definitely a need for more evidence-based management of strategies for skin toxicities of anti-cancer treatments. And really that's where the CaSMO group came about to address this through evidence and systematically. So now I'm going to go through a basic approach for helping managing patients through the anti-cancer treatments. And we'll start with a polling question. So do you recommend skincare products for oncology patients? Do you do it before starting treatments? Yes, but only after experiencing skin reactions, infrequently, or never. And I apologize if you hear any yelling or screaming in the background. It's bedtime for the kids. All right, so the majority of people do recommend skincare products for oncology patients even before any treatment started. So that's fantastic. Let's try and build on that. So in our March 2021 skin therapy letter, essentially what we did is we tried to put together an algorithm for how to try and prevent or reduce severity of skin toxicities and how to manage them as they come up. And this is essentially how it looks. And I'm going to walk you through it. So even before the treatment starts, what we want to do is first and foremost educate patients on cancer treatment and related skin toxicities, and especially the patient, but also clinicians if they are not dermatologists or if they're not familiar with all the skin toxicities. And we really want to set these patients up for success because their skin is going to be assaulted based on any cancer modality, any anti-cancer modality. And the way that I think of these patients is that even if they didn't have eczema to begin with or atopic dermatitis, that's really how they're going to be throughout this journey. They're going to be more on the sensitive skin side. So in order to reduce inflammation and make their skin as comfortable as possible, you ideally want to institute a basic regimen of cleansing, moisturizing, and protection. And so what does that look like? In terms of cleansing, you want to choose a mild cleanser that's ideally within the physiological pH of the skin between 4 and 6. You can reinforce that patients can bathe daily, but it just needs to be less than 10 minutes and mild temperatures. Then immediately after bathing or throughout the day, you want to pat dry and then apply a hypoallergenic moisturizer and repeat as required. And then you really want to explain to the patient that they should be protecting themselves from the sun, either using behavioral methods, either using sun protective clothing or a sunscreen. Rain or shine 365 days a year, primarily because a lot of the photosensitive reactions are driven by UVA in terms of skin toxicities. So we really wanted to make this evidence-based. And so, why would we recommend a regimen like this? There has actually been direct evidence for showing that implementing a dermocosmetic regimen can be beneficial to patients. So this was a multi-centered prospective observation open label study that was used for Cutaneous. Sorry, there's a lot of screaming in the background. I apologize for that. So this was a multi-center prospective observation open label study evaluating implementing a dermocosmetic regimen during systemic chemotherapy. These patients received a quite comprehensive skincare kit that, quite frankly, is too comprehensive for what I would recommend. And then physicians evaluated the skin conditions, and as well the patients scored their tolerability and satisfaction with it. So this was the skincare kit that the patients were provided. It was a study that was supported by La Roche-Posay, and so all the products were La Roche-Posay. This shows the frequency of which products were used the most. And so as you can see, some of the ones that were used most regularly were hand creams, moisturizers, and cleansers. And so if we look at the effect of it, basically what the study did is it broke it down into casual users versus regular users. So that was daily users, and looked at the amount of erythema or redness that the patient would then experience, as well as scaling or desquamation that the patient would experience. So if you look at the regular users versus casual users, particularly the grade 1, 2, and 3 erythema and desquamation, you see that the regular users experience dramatically less erythema and desquamation across the board from grades 1 to 3. And so this definitely indicated that it can help reduce the severity and the incidence of skin toxicities. And then specifically, if you look at the aggravation of skin reactions from chemotherapy, you can see that the casual patients experienced much greater percentage of skin toxicity. So 40% of patients experienced aggravation of skin reactions from chemotherapy versus almost half of the patients that were using the products on a daily basis. So certainly this indicated that there was benefit from it. Additionally, very similar study, a little less complex in terms of the dermocosmetic regimen, but they looked at 253 women that were receiving radiotherapy instead of chemotherapy. Essentially looked at various measures to see how tolerable it was and the effect of it. These were the products that were used in this particular study. So a much simpler regimen, a cleanser, a moisturizer, a hand cream, a sunscreen, and a thermal water. And so this particular study categorized groups into low users or heavy users. And so if you look at the low users, you can see that the time to onset of skin reactions was sooner, and there were more people that developed skin reactions within 10 days or within 14 days. However, the heavy users had statistically lower number of skin toxicities. Then the physicians were asked to score the efficacy of the skincare regimen. And this was really just clinical assessment. And so the physicians for the high users had a positive or neutral scoring of the efficacy of the skincare regimen, much more so than the low users, as you can see. And then finally, and I think this is the most impactful slide of this study, is they took a variety of categories, including looking at how the skin toxicities reduced social impairment, reduced physiological impairment, reduced therapeutical impairment, and reduced physical impairments. And they put this together in a patient benefit index score. And as you can see, the vast majority of patients did benefit from implementing this, more so in the heavy users, less so in the low users. So the study really showed that there was excellent tolerance of products. There was certainly delayed appearance of early skin reactions, and there was a greater benefit linked to the frequency of use. So that's why, based on these two papers that were really high quality and well done, we wanted to kind of simplify it even more and implement just a very simple strategy of cleansing, moisturizing, and protection. So going back to the algorithm, the recommendation is to implement that before you even start the cancer journey, which it sounds like the majority of the audience is doing. You have the anti-cancer treatment, whether that's radiation, chemotherapy, targeted therapy, immunotherapy, hormonal therapy, surgery, or transplant. And then the patient may or may not have a skin side effect. If they don't have a skin side effect, then you continue with the preventative care. If they do have a side effect, the next step would be to identify if it's dangerous or life-threatening. If it's dangerous or life-threatening, the signs that raise red flags are if it's rash with a fever, if there's blister or skin detachment, if there's skin pain rather than itch, if there's mucous membrane involvement, or if there's any abnormal labs such as eosinophilia or hepatitis. If there are any of those signs, they should seek urgent care, either via dermatologist, oncologist, or ER. If it's not dangerous or life-threatening, then the next step, which really gets into more the reaction-specific management, is identifying, is this an exacerbation of a pre-existing skin condition? If so, please implement whatever their pre-existing skin condition management initial management was, or is it a reaction to the cancer or cancer treatment? And if so, then you get into the reaction-specific management, which is beyond the scope of this talk tonight. So again, the basic approach to help managing patients throughout the anti-cancer treatment, ideally, number one is to increase awareness of skin toxicities in order to improve treatment adherence. You really want to educate patients and reinforce that frequent communication to their oncology team is essential to identify and treat adverse events as early as possible, because it's much easier to treat them very early when they're mild versus when they become more and more amplified and severe. And then identifying that regular skincare may help prevent cutaneous toxicities, reducing severity and ideally leading to improved patient outcomes. So again, the March paper went over a comprehensive algorithm. It's basic, it's just a framework to understand and a checklist to go through when you're faced with a patient that's ideally about to enter the anti-cancer journey, or maybe they're coming to you after they've had their treatment, but really highlighting that these patients are going to have their skin assaulted by the anti-cancer treatment. And in order to set them up for success, implementing a very simple dermocosmetic regimen with gentle cleansers, hypoallergenic moisturizers, and regular sun protection can put the patient's skin in the best possible shape to go through this journey and ideally reduce treatment discontinuation and interruption. So with that, I'll open it up to the final polling question. Now that Dr. Lin and I have gone through this, are you now more comfortable in recognizing and starting a basic management of patient skin toxicities, skin toxicities during cancer treatment? Yes or no? Wow, that's fantastic. So looks like Dr. Lind, I think we're successful in our objectives. 97% of you agreeing that you are more comfortable with managing. And with that, I will hand it back over to Roxanne.
Well, thank you so much, Dr. Sauter and Lynn, and that's really encouraging to see that our audience is and feels more comfortable in treating with these cancer patients. And we'd like to also thank our sponsor, La Roche-Posay, for making, again, this educational event possible. So we have time to go to our question and answer period. Again, please submit your questions using the question chat pane on the right-hand side of your screen. And if there's any additional questions you think about afterwards, you can always send them to info@rbcconsultants.com. So with that, if Dr. Lynn, you can come back with your camera. And the first question from the audience is, with an increasing number of drugs used in the treatment of cancer, how does the average physician stay up to date? Any suggestions?
I'll take that one. Max. Yeah, I find it, to keep up with this is not sort of things that are in our realm every day. We've got so many other drugs that we need to know about, biologics and JAKs and everything else. Again, I'm lucky enough to have a oncologist that I'm that I can text or I can phone, ask him which kind of drug is this, and is this I'm suspecting this reaction. Is that one that you've seen before or think about? You can also go to LIT and go. I often use Google too to try to identify some of these things. But most of them, a lot of them, there's certain patterns that you see, and once you've seen some of these patterns, you go, that's what it is. And there's certain drugs that seem to cause some of these certain patterns, and you just go to that. Max, do you have anything else you do different? You see more of these than I do.
I mean, I must admit, even working at a cancer center and even working with our phase 1 clinical trials group at the cancer center, it's challenging to stay on top of all the anti-cancer treatments. But there have been fantastic review articles, even trickling into the dermatology literature. But, really it's just a matter of speaking with your oncology colleagues, or when you don't recognize something, looking it up and seeing what it's kind of similar to, and identifying, okay, this is a targeted therapy, so maybe I'm thinking more in the targeted reactions. What are the more common targeted therapy reactions, such as the acneiform reaction that you identified, or the hand-foot skin reaction, et cetera, et cetera. But it's challenging. It's, with oncologists, they're usually quite focused in terms of the malignancy that they're dealing with. And so they can basically keep blinders on for their specific disease. And so they can become they're experts in those treatments. But keeping on top of all of them is a challenge when you add on all the disease sites, all the different solid tumors, all the different hematologic malignancies.
And unfortunately, many of the oncologists call it, oh, Max, my patient has a rash, which it might be prurigo nodularis, bullous pemphigoid, psoriasis. Right. There's so many different things. As I mentioned earlier, you can go to Skin Therapy, and those letters have each of these things. And we're actually creating a series. So one of the next series will be about immunotherapy and the reactions you see and how you treat them. So again, you'll have a little sort of series of ones. And as I mentioned before getting into this area, I really was amazed that there wasn't really as much in the literature, despite the actual overwhelming number of people in Canada and elsewhere in the world that get malignancies. And everybody was kind of hopscotch from doing, nothing at all, to giving everybody prednisone kind of deal. So it's important I think for people to try to keep up as best they can. And even, as Max said, there's a number of new ones that are in clinical trials. And sometimes, unless your oncologist, when they send you along and tell you which this drug is, in which kind of grouping it is, you often don't have an initial clue. But we're dermatologists and we've got eyes, we know the difference between bullous pemphigoid. We know the difference between prurigo nodularis, and I think we also know generally what we should be doing there to be able to help these patients.
Yeah, and I think that's a really important point, that when you don't know exactly what's going on, understanding that oncology patients are no different than the rest of our patients, and when in doubt, use your morphology and also pathology to help guide your treatment further.
Yep. Maybe I've got a quick question, Roxanne, for Max. I was wondering, when you were giving your talk about bullous pemphigoid, is there any difference in a person that is 80 years old, say, on a drug X, such as pembrolizumab, and a person that's 25 years old on that same drugs in the incidence of the bullous pemphigoid? In my sort of simplistic mind, I go, that person that's 80 is more likely to get that bullous pemphigoid because of their immune system and everything else. Is that true, or do the incidents sort of the same? You know, a person with melanoma at age 25 getting the drug, or a person that's 80 years old getting that same drug, the reaction of bullous pemphigoid. Max?
Yeah, so I think it's a really fascinating question, and the short answer is we don't have good statistics on it. But my anecdotal data from, well, not anecdotal, but my case series that I manage, you're much more likely to develop bullous pemphigoid in your 70s or 80s versus the 20 or 30-year-old. The 20 or 30-year-old is much more likely to have more immune-related adverse events because of their healthy, robust immune system, but it usually tends to be of other organs, so pneumonitis, colitis, hepatitis, even hypophysitis, and their inflammatory skin reactions, I find, tend to be more eczematous or psoriasiform. But I think that it's a combination of these people are predisposed to getting bullous pemphigoid. They're also potentially on some other concomitant medications that may predispose them. Perhaps they're diabetic, perhaps they're also on a DPP4 inhibitor that is another risk factor for developing bullous pemphigoid. And then you put fuel on this fire with an immunotherapy, and boom, you get bullous pemphigoid. So I think the youngest patient I've seen with bullous pemphigoid in the setting of immune-related adverse events was about 50. I need to go back and look at all my cases, but I really haven't seen anyone much younger than that.
Thanks, Max.
So another question from the audience is, what are some products you recommend for the dermal cosmetic skincare regimen?
Yeah. So again, I treat these patients like they have eczema. And one good resource that I like to recommend to a lot of patients is producteliminationdiet.com. That's a website that's put on by Sandy Scott Nicky. And she really goes through most of the product ingredients to see, to make sure that there's no preservatives that people could react to. But I also like to follow the evidence, and I presented 2 excellent papers today that show clear benefit in both the chemotherapy and radiation therapy setting. So in terms of cleansers, I do certainly recommend Lipicar Syndet from La Roche-Posay. In terms of moisturizers, I regularly recommend Lipicar Balm, as well as CeraVe cream. And then in terms of sunscreens, I do tend to recommend more physical sunscreens with zinc or titanium or both, because I feel as though they get a better UVA coverage.
And these products are over the counter, are they not?
These comments are all over the counter, yes.
Okay, great. And then a last question. I'm not sure if you understand it. I'm not sure if I understand. On what surface do you apply the cream? I'm not sure if on what surface.
So, if you're talking about a moisturizer, you're head to toe. So you pat dry and go from head to toe.
I think it may have also, Max, to do with some of the radiation ones I showed with ulceration. You may not necessarily just be wanting to use a moisturizer there. You may want to be using other modalities until you get the barrier much better. I think that maybe has to do with it. So yes, so you treat that burn as if it was a burn, get the barrier function a lot better, and then subsequently use some of these other things. I think that what Max drove home there was a lot of the idea is prevention. You've all heard that saying about the ounce of prevention better than the pound of cure, and that's something I've already had. You know, this publication's been out just a relatively short period of time. I think this CaSMO group is actually changing things, the paradigm, certainly among the radiation oncologists. I can still remember I was taught, and they basically, the radiation oncologist said, you burn the heck out of the breast or the neck, and you just leave it there. You wait until that thing falls off, which included the head, you know. And please do not touch it. Do not look after any infection, nothing. And that's been the paradigm. And I think there's been a whole generation of radiation oncologists that have been taught that. But already people are starting to read this and go, oh, it doesn't make sense anymore. And people are understanding about how you treat wounds, how you treat the skin are much better. And I think the days of when there was kind of everything was eminence-based, right? You trained at a certain center and your boss told you that's what it was. And he told the 10 trainees that's the way it was. And those 10 trainees went back to their different centers and told the rest of the people that's what it is. I think with the dissemination of knowledge, you know, you can press your iPhone, you can press your computer, and you're all over the world, and it's reading different papers. I think the knowledge is getting through there, that there needs to be a change in this area. What also impresses me that, you know, La Roche-Posay is sort of taking up the flag here. I can't understand why other companies in this realm has really not kind of gone after this, because it's certainly an area, as we mentioned, very pervasive in our population, and they need education. They need to know what they're doing, and vice versa. I think physicians need to know that. It wasn't talked about. When I was a trainee in dermatology, nobody talked about anything like this. And I can't really see from the podium that until recently, there really hasn't been much from the podium either in how to treat these. And yet we have all of these patients in our practices.
Well, that's all the time we have. So we'd like to thank Dr. Sauter and Dr. Lynn for a really insightful and practical presentation. And remember, to all of you watching tonight, we have another series, a webinar. The next one is going to be an algorithm for radiation. So that'll be interesting, skin toxicities and radiation. And as Dr. Lynn mentioned, the one after that for immunotherapy. So thank you so much for joining us. Good night.
Good night. Thanks, everyone. See you, Max. See you, Roxanne.
Good night.
Bye.
Take care.